Hi guys, my name is Diana Villamar and I am going to talk about two topics in this video. First, I will talk about Ribavirin for chronic hepatitis E virus infection in transplant recipients. Definition: Hepatitis E is a liver disease caused by infection with a virus known as hepatitis E virus. The virus has at least four different types: genotypes 1, 2, 3, and 4. Genotypes 1 and 2 have been found only in humans. Genotypes 3 and 4 circulate in several animals.
Hepatitis E is RNA virus. Spread by the fecal-oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged viremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank you for watching. For more videos, subscribe to our channel.
Applications in medicine. The hepatitis E virus is transmitted mainly through the fecal-oral route due to fecal contamination of drinking water. The route accounts for a very large proportion of clinical cases with this disease.
So now let's meet some patients so we can put to work what we have learned about hepatitis E diagnostics. Our first patient is Hannah. She feels sick and had to vomit at home. She's feverish and her skin has a yellowish color. Her symptoms started 1 week ago. 4 weeks ago, she came back from Mexico when she visited family. Obviously, we think about hepatitis. Let's order lab tests. In Hannah's lab report, we can see that her liver enzyme function is significantly elevated. Furthermore, her hepatitis E tests are positive. Hepatitis E RNA is also detectable. So what's your diagnosis? Hannah has no history of immunosuppression. So let's take a look back at the graphic dealing with immunocompetent patients. Her ALT is very high, which signifies serious liver damage. Anti-HEV IgM and IgG are both positive, and we could detect RNA in Hannah's stool. Based on these results, we can conclude that Hannah is most likely in the early phase after infection. So Hannah is suffering from an acute hepatitis E infection. Let's see our next patient. Our second patient is Pete. He suffers from abdominal pain of recent onset. In the lab report, we can already see elevated liver enzymes. Pete received a lung transplant 8 years ago. Currently, he is on immunosuppressive therapy. Furthermore, he tells us that he's a passionate hunter. Based on Pete's history, we include hepatitis E screening in our lab report. We can see that his liver enzyme function is significantly elevated. His anti-HEV antibodies are negative. However, the lab detected HEV RNA in Pete's stool. What does that mean? Since we know that Pete is taking immunosuppressive medication, we should consider this in interpreting his lab results. We know that immunocompromised patients can have problems producing antibodies to the virus. So in Pete's case, it is essential to measure RNA. His lab report shows elevated ALT levels as a sign of liver damage, but negative antibody tests. However, there is RNA detectable in his stool. Pete is suffering from an active, ongoing HEV infection. Based on the laboratory findings, we cannot determine when Pete was infected. It may have been recently or more than 6 months ago. However, it is not important to know that. What is important is that Pete gets appropriate treatment and follow-ups. Congratulations! Now you can handle hepatitis E lab results.
So I hope you liked this video. Absolutely make sure to check.
Pros and cons. In rare cases, acute hepatitis E can be severe and result in fulminant hepatitis. These patients are at risk of death. Fulminant hepatitis occurs more frequently when hepatitis E occurs during pregnancy.
Hepatitis E is a viral hepatitis, liver inflammation, caused by infection with a virus called hepatitis E virus. It is one of 5 known human hepatitis viruses. A, B, C, D, and E. Hev is a positive sense single-stranded non-enveloped RNA icosahedral virus. Hev has a fecal-oral transmission route. Infection with this virus was first documented in 1955 during an outbreak in New Delhi, India. A preventative vaccine, F239, is approved for use in China. Although hepatitis E often causes an acute and self-limiting infection, the virus usually resolves itself and the individual recovers, with low mortality rates in the Western world. It bears a high risk of developing chronic hepatitis in immunocompromised patients with substantial mortality rates. Organ transplant recipients who receive immunosuppressive medication to prevent rejection are thought to be the main population at risk for chronic hepatitis E. Furthermore, in healthy individuals during the duration of the infection, the disease severely impairs a person's ability to work, care for family members, and other daily activities. Hepatitis E occasionally develops into an acute, severe liver disease, and is fatal in about 2% of all cases. Clinically, it is comparable to hepatitis A, but in pregnant women the disease is more often severe and is associated with a clinical syndrome called fulminant liver failure. Pregnant women, especially those in the 3rd trimester, suffer an elevated mortality rate from the disease of around 20%. Hepatitis E newly affected about 28 million people in 2013.
This is a player in Ecuador. Every year, there are an estimated 20 million HIV infections worldwide, leading to an estimated 3 million symptomatic cases of hepatitis E. And conclusion. In conclusion, Ribavirin has monotherapy may be effective in treating chronic HIV infections. A 3-month course seems to be an appropriate duration for this therapy. Such a launch therapy can be given to heavily immunosuppressed patients and those who still have viremia a month after the initiation of therapy.
Hepatitis E virus, referred to as HEV, is a common cause of sporadic and epidemic acute liver disease in developing countries. In the United States, sporadic cases of both imported and locally acquired HEV infections are mostly seen among adults. Incubation ranges from 15 to 60 days following exposure, with an average of 40 days. Liver enzyme elevation, as shown in blue and labeled ALT for alanine aminotransferase, usually occurs 4 to 5 weeks after exposure to HEV and persists for 3 to 13 weeks. Symptoms noted by the purple bar occur when liver enzymes are elevated. Virus excretion in stool, illustrated by the orange bar, is variable, but usually lasts from about 1 week before symptoms appear until about 1 week after they have surfaced. However, this time frame can be longer in some people. Viremia in acute self-limited infections, shown by the green bar, can be detected about 3 weeks following exposure or a week or so prior to onset of symptoms and lasts for about 2 weeks. Antibodies to HEV, both IgM anti-HEV, depicted by the pink hatched line, and IgG anti-HEV, illustrated by the black hatched line, are usually positive about 3 to 4 weeks after exposure. IgG anti-HEV persists, but IgM anti-HEV declines rapidly during early convalescence and is usually negative by 13 weeks. HEV serologic testing in persons with acute hepatitis for which other causes have been ruled out may be performed, especially in someone who has recently traveled to an area where HEV infection is more common. Chronic HEV infection is rare, but has been increasingly recognized in immune-compromised patients. Immunoassays to detect anti-HEV are commercially available, but are not FDA approved. Nucleic acid tests for the detection of HEV RNA are performed in research labs, but are not commercially available. This segment is now complete.
The second topic is immunotherapy in renal cell carcinoma and definition. Immunotherapy is the use of drugs to boost a person's immune system so that it recognizes and kills cancer cells. More affected by several types of immunotherapy can be used to treat kidney cancer.
I think the most interesting data and the one that people are very excited about is the Emotion 151 that we just heard from Dr. Bob Moser. And this is a phase 3 randomized trial that looks at bevacizumab with atezolizumab versus sunitinib in a phase 3 setting for advanced metastatic clear cell kidney cancer. So let me just give you a little background on how we treat kidney cancers or advanced kidney cancers. So certainly there has been a lot of landscape changes. In the past, if we go back even a decade ago, we really did not have a lot of systemic therapies to offer. But now we have VEGF inhibitors, so these are what we call the TKIs. And certainly we have the immunotherapy drugs, but mostly for second line right now. So with the advent of these trial, the landscape of treatment is really changing. So in this phase 3 trial, though, what they saw was a phenomenal and very compelling improvement in the progression-free survival. The overall survival is yet immature, but we are seeing that there is two co-primary endpoints. One is progression-free survival in patients who are PD-L1 positive, and in this population there was about 40% of them, as well as an intent-to-treat population. And what they found was the PFS, for instance, for the combined therapy is in the order of 11.2 months, compared to only about 7 months for the sunitinib arm. So these are compelling data. And in terms of toxicity, actually there's not a whole lot that it's unexpected, if you will. So I think it's a fairly tolerable regimen. So I think moving forward, this is a great candidate. Perhaps, we will be seeing more this year. I think it's rapidly evolving. And the trial I just mentioned, the emotion trial, is but one of them. Last year at ESMO, we heard about the Checkmate 214 trial, which looked at the combination of nivolumab and ipilimumab versus, again, sunitinib, and that was also a positive trial. So we are starting to see now these combination IO drugs that are pretty soon going to be changing the landscape of treatment, because right now IO therapy has largely been second line therapy with nivolumab. So I think we are starting to see these agents move up, and not just maybe single agents, but in combination.
Applications in medicine. Pembrolizumab and nivolumab are drugs that attack PD-1, a protein in cells of the immune system called T cells that normally help prevent these cells from attacking other cells in the body. By blocking PD-1, these drugs boost the immune response against kidney cancer cells. This can often screen or slow the growth of some tumors.
So the next wave is these checkpoint inhibitors. There's at least 4 or 5 trials that I know of. I think only one with atezolizumab that's actually up and running. Others with nivolumab and durvalumab, and also, any drug you can imagine will be tested in that setting. It probably makes a lot more sense. It's going to be better tolerated for patients, I think. I think probably has the potential to extend overall survival, which would be ideal, which we haven't done to date, even with S-TRAC. And so we'll have those results in many years, but I think probably if we're sitting here in 5 to 10 years, we'll be talking about those drugs as standard of care.
Pros and cons. Pros: helps the immune system work better to kill cancer cells, helps stopping or slowing the growth of cancer cells. And cons: difficulty falling asleep or failing asleep, weight loss, feeling tired, diarrhea, fever.
Renal cell carcinoma is the most common type of kidney cancer in adults. It accounts for approximately 3% of adult cancers, and the incidence has risen steadily by about 2 to 4% each year in the past few decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones. While the exact cause of renal cell carcinoma is unknown, there are risk factors that increase the chance of developing it, such as smoking, high blood pressure, family history of kidney cancer, and obesity. The chance of developing renal cell carcinoma increases with the age, and males have double the chance of having it compared to females. In a lot of patients, this cancer may not produce any symptoms for most of its course. Only about 10% of patients present with the classic triad of flank pain, blood in the urine, and lump in the abdomen. Other signs and symptoms may include unexplained weight loss, fever, night sweats, weakness, fatigue, nausea, and high blood pressure. Renal cell carcinoma is associated with a number of paraneoplastic syndromes, which are conditions caused by either the tumor hormones produced by the tumor or by the body's attack on the tumor. In about 20% of these patients, paraneoplastic syndromes are present, such as high blood calcium levels, high red blood cell count, high platelet count, and deposition of amyloid protein in one or more organ systems. To diagnose renal cell carcinoma, signs and symptoms and past medical history play significant roles. Based on the symptoms and signs, a range of biochemical tests are considered to provide sufficient diagnostic clues. Kidney imaging is vital, mainly consisting of ultrasound, CT scanning, and MRI scanning of the kidneys. Biopsy of the suspected kidney mass helps confirmation of the diagnosis. To evaluate the extent of cancer spread, PET scanning is the standard imaging modality. The therapeutic approach to renal cell carcinoma is guided by the stage or degree of tumor spread, pre-existing medical conditions, and overall health and age of the person. The principal treatment options for renal cell carcinoma consist of surgery, immunotherapy, and targeted therapy. Partial or complete removal of the affected kidney is the standard treatment for localized renal cell carcinoma. Immunotherapy, or biologic therapy, works by boosting the body's immune system to help destroy cancer cells. Cytokines are the artificially engineered versions of natural proteins that activate the immune system, and the ones most often to treat kidney cancer are interleukin-2 and interferon alpha. The targeted therapy works by blocking growth of the new blood vessels that nourish cancer cells or downplaying important proteins in cancer cells that help them grow, or both. Clinical response rates with chemotherapy, either monoagent or combination, are usually less than 15%. Renal cell carcinoma is not very sensitive to radiation, and radiation therapy is more often used to palliate or ease cancer symptoms in case of cancer spread. For more information about list of expert doctors, hospitals, and ongoing clinical trials, please visit www.expertdocs.com.
Issues appear in Ecuador. Until now, only targeted therapy existed, but it was an option for a small group of patients, 25 to 30%, who presented some molecular alteration. The rest only received chemotherapy and therefore have a short life expectancy.
The discovery of the von Hippel-Lindau gene in clear cell renal cell carcinoma in 1993 has really led to a tremendous increase in our understanding of kidney cancer biology, specifically clear cell renal cell carcinoma biology. The VHL gene, when mutated, results in upregulation of HIF, or hypoxia-inducible factor, which results in a very angiogenic tumor. So we have a whole series of agents that have been developed looking at that actually target this, either the VEGF itself or the receptors, drugs like sunitinib, pazopanib, axitinib, cabozantinib, and lenvatinib. The other thing that we know about renal cell carcinoma, and again, particularly about clear cell renal cell carcinoma, is that they're very immune infiltrated, and this actually provides us with real opportunities to use novel checkpoint therapies. So a lot of the things that we're seeing now that are coming out are these combinations of immunotherapy, blocking checkpoints, as well as anti-angiogenic agents. The last thing that's really happening is that with our understanding of HIF biology, agents that actually target HIF1 alpha, or more importantly HIF2 alpha, have also been developed, and there's going to be some exciting new things coming out over the next few years in that arena.
VEGF has been a target in renal cell carcinoma for the last decade, and I think VEGF therapy is actually still a mainstay of treatment for the disease. We've proven that sequential VEGF therapy can have therapeutic impact, and the VEGF pathway is key to renal cell carcinoma angiogenesis and pathogenesis in general. Novel targets for renal cell carcinoma can be looked at more broadly than just the VEGF pathway, but recently what's really interesting are HIF2 alpha inhibitors that sort of inhibit the VEGF pathway at its base, and we'll be hearing about some of those at the meeting this week. We're fortunate, those of us who treat kidney cancer, to have multiple options, multiple drugs that we can select for our patients. But really, I think of it as three categories of drugs currently. We have VEGF inhibition, we have mTOR inhibition, and we have immunotherapy with checkpoint inhibition. And so it's really only three mechanisms of action. They're very different. VEGF inhibitors are targeted tyrosine kinase inhibitors. mTOR inhibitors target a different pathway. And then immunotherapy is separate altogether in that it really targets the immune system, the T cells, to engage with and activate to fight the cancer. And so what's fascinating is when we combine these, that we've seen really synergistic activity among certain versions of these drugs. So for instance, combining axitinib or lenvatinib with immunotherapy looks to be safe and effective. And then combining lenvatinib with everolimus similarly seems to be safe and effective. And so those combinations really have sort of upped our game and our ability to get better treatment responses for patients.
In conclusion, immunotherapy is a current treatment against cancer, which in this study has been shown to be effective and well tolerated, presenting fewer adverse reactions than conventional treatment. And finally, video.
The most common form of cancer in the lower urinary tract, or the bladder and the urethra, is transitional cell carcinoma, or TCC, and to be more specific, urothelial cell carcinoma, or UCC. While this cancer can affect tissues in the upper urinary tract, like the renal pelvis and the ureter, it most commonly arises in the urothelium of the bladder. Watch the full video on osmosis.org. Watch the full video on osmosis.org.
Thank you.